a year ago, I was directing telestroke and teleneurology for Mayo Clinic, and this year I find myself with a tremendous opportunity for which I'm extraordinarily grateful, and that's to work within our organization to design, develop, and implement connected care, and in particular synchronous telemedicine, for all medical and surgical disciplines within the organization. For many of you in the audience, you would, who are in a similar role, you'll agree, I think, that this is extraordinarily challenging. Number one, to work across an entire enterprise as opposed to be working within one segment or campus or component of your organization. And number two, to be working with professionals that you now find are outside of your domain of expertise. So as a neurologist, I'm now working with psychiatrists and pediatricians and general surgeons and intensivists and across multiple campuses in the institution. That's also happened in the past year. But it's an extraordinary pleasure for me to challenge myself and work to that capacity. So I'm going to speak to you about Mayo Clinic Center for Connected Care. I will start speaking generally about the Center for Connected Care. Then we'll focus attention on one particular domain of the center, the synchronous aspect, telemedicine as we sometimes call it, and then underneath that speak about telestroke. So in the presentation you'll have a sense of what the organization is doing around connected care in general, and then at the other end of the spectrum to focus in on the successes of one particular telemedicine service line. For those of you that are less familiar with the organization, you'll recognize it's the first and largest integrated not-for-profit medical group practice. Globally, it's a worldwide leader in medical care, research, and education, which I alluded to earlier, representing the three shields of Mayo Clinic. It employs 60,000 personnel and annually cares for over 1 million people in over 150 countries. Its primary value is that the needs of the patient come first. And this is what the organization has witnessed over time. It started with an established practice in Rochester, Minnesota, a hospital practice, an ambulatory care practice, and then the development, first in the Midwest, of regional health systems, and then with trials in the Southwest, in Arizona, Southeast, in Florida, of Mayo Clinic campus expansion. And that brought the organization to where you see the peak of the blue curve, and then a recognition by the organization and other organizations that there's a need to determine how a health system can remain relevant in a new era. And so Mayo Clinic began to make some fundamental shifts and changes in the way it viewed itself and the way it began to interact with its patients and clients and other providers. So connected care emerged. It was initially referred to as e-health and telemedicine, but we've adopted the term connected care more recently. Programs like Ask Mayo Clinic Nurse Triaging, a portal so that patients could connect with their providers, the opportunity for providers to seek asynchronous e-consultation advice from medical and surgical specialists, the concept of an affiliative network that was brought up in the panel discussion, the Mayo Clinic Care Network emerged, an affiliated consumer network, and then e-health, telemedicine, and connected care. Which is, as I said, the chosen term. So this is an example of how one organization recognized the need to remain relevant in this domain of the necessity and shift of interacting with patients in a way other than bricks and mortar and face-to-face. So from the patient's perspective and the provider perspective, historically, here's an example of Dr. Mayo actually making house calls with a cart and horse and medical equipment in the bag. Then a focus of attention on an acute care facility or hospital. Then the involvement of more ambulatory care and multi-specialties. And then the patient is now experiencing an opportunity to interact with their care providers in a virtual manner by mobile devices, tablets, smartphones, and for providers to interact with patients or other providers via other consultative routes like a direct audio-video connection. The Center for Connected Care at Mayo Clinic elected to develop its vision statement in alignment with the institutional vision statement. So Mayo Clinic's vision is that it will provide unparalleled experience as the most trusted partner for healthcare. And in the Center for Connected Care, we elected to create our vision to connect Mayo Clinic knowledge and expertise to anyone, anywhere, anytime, and for the center to be the most trusted and provide an unparalleled connected care experience for its users. And this is the concept for the Mayo Center for Connected Care, dividing at the left-hand side connected care into a number of different domains: synchronous care, asynchronous care, remote monitoring, and mobile health. At the other end of the top right-hand corner are the consumers of care, the formal Mayo Clinic campus practice, the Mayo Clinic Care Network affiliates, and a broader consumer network. And the center conceptualized itself as being in the middle. So the center represented the people, the space, the technology, the governments and policies, as well as innovation and research that would facilitate the need for those domains of practice to build them and then to deliver them to consumers, both within and external to the organization. This was the concept for our program. We recognized that different telemedicine or connected care in general programs were at different stages of development. And we categorized those early programs to being mature, embryonic, or imagined. And so some examples, historically, the things that emerged first were e-consultations, video visits, an eICU program, a patient portal, e-tumor boards. These mature programs, the Center for Connected Care elected to diffuse. Because of their level of maturity, they were proven. Embryonic programs a year or two ago included telestroke, an infant-guided resuscitation, an emergency department, remote monitoring, and these needed some refinement before they could be construed or categorized as mature and diffuse. And then there were imagined programs such as robotic surgery, emergency transport, and interactive care plans, which required development. And then those that were developed became, there was an opportunity to refine. Those that were embryonic and refined, there was an opportunity to classify as mature and diffuse. So examples of infant-guided resuscitation and telestroke are now mature programs and in the process of enterprise-wide diffusion. So this was a conceptualization of the stages of development in our organization that I think serves well for other healthcare institutions engaged in connected care. And then we define different domains, as I said. So the live video or telemedicine domain as synchronous, the store and forward asynchronous process, remote monitoring, and mobile health. And we wish to ensure that these four major domains had an opportunity to facilitate transactions between providers and patients and providers across the entire continuum of care, all the way through from prevention, the presentation of the patient with an acute problem, the diagnosis, treatment, recovery, and ultimately management, and back to reintegration into the community and secondary prevention. So with that background of the Center for Connected Care and the 4 domains and our process for moving through mature, embryonic, and more imagined programs, let me focus the remaining attention on this particular domain of live video, synchronous, or telemedicine, and then ultimately of telestroke. Video consults and visits are one of the programs that the center is highlighting, and this is an opportunity for anyone within the organization and connected to the organization to have a live synchronous video consultation with a member of a medical or surgical subspecialty. It's improved access to specialty care. It's proven to overall reduce the cost of care. It's reduced travel and inconvenience for both patients and family members, as well as for some providers that were accustomed to traveling for outreach. And it has proven patient and provider satisfaction. In the year 2015, over 2,000 such video consultations and visits were conducted. And these are the top practice areas, as you can see here: infectious diseases, endocrine, cardiovascular, GI, nephrology, and general internal medicine. So these were for non-urgent, non-acute consultations and for follow-up. Where Mayo Clinic began with the tools necessary for video visits and consults is what one of our colleagues has labeled as the starter set. This is the standard video client, a high-definition camera, desktop, laptop device, video otoscope, so a few peripherals, a wired network, and business hour support. What we're moving toward by the end of this year is an advanced set, a much simpler provider and patient user experience, so that the tools will be easily I should say, easily incorporated into the clinician's practice, not just the progressive, innovative type clinician, but the average clinician at our institution will find this easy to incorporate into their practice. Call management queuing, virtual waiting rooms, mobile access, not limited to the desktop and laptop, having real-time quality reporting, and having dedicated technical support. And ultimately, by 2018, we would like to move to an ultimate package of advanced functionality so that there's internal or direct scheduling, there's an opportunity for medical record review, even in environment of disparate electronic medical systems, there's an opportunity for these systems to address revenue generation, billing, and coding, that there be automated licensure and credentialing validation. If you have pools of medical and surgical specialists across multiple states, to ensure that a particular specialist that's tagged has the appropriate license and credentials to actually provide the consultation, and if not, to redirect that consultation or call, test calls, integrated clinical documentation, and guaranteed performance. So this is the spectrum, again, from starter to ultimate, in the way that we would like to provide the tools necessary for Mayo Clinic clinicians to be engaged in connected care. So if we leave for a moment the non-urgent or ambulatory video visit and move to emergency video telemedicine, there are many organizations that are engaged in real-time, time-sensitive emergency telemedicine. Stroke is a perfect example. Critical care is another excellent example. What Mayo Clinic is embracing and developing is a multi-specialty, integrated and comprehensive emergency telemedicine program that could address in a moment any pediatric or adult emergency that is submitted at a push of a button, for example, from any of the campuses or any of the affiliate hospitals. So a rapid access to multi-specialty consultation, not only directed to individual specialties, but teams of specialists could be engaged to help with the diagnosis, guidance of care, and remote monitoring for these patients with high-risk emergency situations. we're developing a program that will span from the pre-hospital environment all the way into an acute care facility that is off Mayo Clinic campus or on Mayo Clinic campus, and then in various geographic regions across that acute care facility. We wish for it to accelerate patient triage. We want it, of course, to improve clinical outcomes. We want to be sure that we're developing a system that can make appropriate decisions regarding the needs of the patient and transfer decisions, disposition, and that the technology that's incorporated will work nearly flawlessly every time. Just as we heard others speak earlier in the session, the importance in connected care to ensure that we're developing technologies and programs that will handle emergencies in the same way as we push ourselves to handle face-to-face emergencies in that fashion. That the same sort of degree of rigor and quality and care should be built into it. So at the moment there are 4 active hub sites within the Mayo Clinic system in Rochester, in Phoenix, and in Jacksonville, as well as in the Mayo Health System, providing emergency telemedicine to 60 health systems and hospitals, over 3,000 activations for such care in 2015, and the major programs to date have been stroke, neurology, hospital or emergency neurology, neonatal resuscitation, and critical care, and emergency medicine. So we're imagining a real and virtual control center whereby the consultative alerts come into a centralized dispatch, for example, and then sent out to either individual or teams of specialists to engage with the requesting provider and the patient. So a few examples then. We're going to focus attention on stroke and neonatology, and then the last part of the presentation will be an emphasis on telestroke, one example. But our Mayo Clinic story has been the following with telestroke. These are the parameters, some of the parameters that we have, metrics that we have followed for some time. We've recognized that telemedicine for the acute stroke patient has provided 98% accuracy for diagnosis and decision-making, and has resulted in a 10-fold increase in the utilization of the clot-busting medication TPA for stroke. There's a 1-minute median response time to the neurological consultation request. Most of the stroke consultations take approximately 20 minutes or less, so it's a rapid assessment. Safety, there was some concern that virtual consultations for stroke and the recommendation for administering the clot-busting medication in such a fashion would result in more brain bleed complications than in real practice, but that's not the case. The percentage is approximately the same in our face-to-face practice. We have successfully reduced unnecessary transfers by air and ground ambulance by 65%, by having neurologists available to those remote community hospitals in diagnosis and decision-making. And the morbidity and mortality of the stroke patient in the virtual sites is comparable to the stroke patient's morbidity and mortality at Mayo Clinic campus proper. And nearly 10,000 patients have already been impacted by the program. In neonatal care, it's a program that has been in existence for a shorter interval of time than stroke. But to give you some idea, from the Midwest component of Mayo Clinic, there were 84 tele-neonatology resuscitation care episodes over 2 years. It's been a win-win for the organization. A third of the babies remain in the local hospital. About half of them are transferred to the Mayo Clinic neonatal ICU. And you can see how the increase in utilization of the tele-neonatology program, and this has been the longest period of time without a settled birth injury case in the last 12 years in the history of neonatology at Mayo Clinic. So it's had real impact each time that it's activated. So I'm going to end with talking to you about the telestroke story at Mayo Clinic and taking it across the continuum of care. This is what we construct as the continuum of stroke care from pre-hospital all the way through to discharge and reintegration in the community. And we've discovered that there are avenues for connected care at every aspect of this continuum. And for each of these facets of the continuum of care, it's important that our organization, like yours, is concerned with satisfaction of patient providers, and that there's research and metrics surrounding quality, just as you've heard from the panel discussion. So speaking of pre-hospital emergency medicine, there has been an emergence of using in ambulance telemedicine, either telemedicine in ordinary ambulances or telemedicine in carefully constructed stroke ambulances that include a CT scanner to exclude a brain hemorrhage and have point-of-care laboratory studies and drug, the clot-busting drug, to administer at the site of the patient or en route to a stroke center, as opposed for all of those activities to happen at the stroke center. And here's an example of that. Pre-hospital telestroke by air ambulance. We were one of the organizations to do some piloting work of whether it was feasible for a neurologist at the Mayo Clinic in the background stroke center to conduct a stroke assessment of, in this case, a volunteer pretending or posing to have had a stroke. If it was feasible to do those assessments in flight in advance of the patient arriving in order to shave time off the stroke onset and the administration of stroke treatment by doing the clinical evaluation en route as opposed to waiting until the patient arrived at the hospital. And for one of you lucky folks who will win a drone tomorrow, as I understand, drones have also been incorporated into the telemedicine pathways for other time-sensitive emergencies. For example, in cardiovascular medicine, in out-of-hospital cardiac arrests, there have been experimentation of drones equipped with telemedicine and resuscitation tools in order to supplement or complement the existing 911 and EMS pathways that exist.